America's healthcare system is almost unanimously viewed as being unaffordable, dysfunctional, and severely in need of transformation. APG President and CEO Don Crane talks with leading healthcare executives, physicians, and other visionaries to explore solutions to lowering costs and improving quality of care by accelerating the movement toward value-based care models and away from fee-for-service. Want to be inspired by our nation's foremost thought leaders in healthcare? Then this show is for you. Here's your host, Don Crane.
I want to thank the TDC Group, the exclusive sponsor of our APG on American Healthcare podcast. We're glad to have you on board. TDC Group has been serving healthcare organizations and practitioners for over 40 years. They are the nation's largest physician-owned provider of insurance, risk management, and healthcare practice improvement solutions. They work with a range of large and small healthcare groups nationwide. TDC Group is endorsed by such well-known organizations as the American College of Cardiology and the American Society of Plastic Surgeons. To learn more, visit their webpage, thetdcgroup.com. The consolidation of healthcare entities, and whether it is a good thing or a bad thing, has long been a topic of debate across the country. But two recent events have moved the subject to the front pages of the nation's newspapers and make it appear likely that it, and measures to regulate it, will pose significant strategic challenges for all of the players in the healthcare ecosystem. One of those events was the lawsuit against Sutter brought by Xavier Becerra, the California Attorney General. The other event was the confirmation of that very same person as the nation's Secretary of Health and Human Services. Given the heightened state of interest in this topic, I thought it would be wise to talk with one of the many economists that have gained national attention recently for their studies on the effect of consolidation on the cost and quality of care. One of those experts is Glenn Melnick, professor of health administration and economics at the University of Southern California, who has studied the matter and testified about it extensively. I think you'll find his comments interesting and provocative. Take a listen. APG friends and listeners, we have a treat in store for you today. As you know, the word consolidation is a hugely important word in today's healthcare arena. We have a Secretary of HHS who seems very interested in the subject of consolidation, and we read article after article sort of asserting that consolidation in healthcare elevates prices and cost, but does not improve quality. And so to probe into that subject, we're fortunate to have with us today Professor Glenn Melnick, who is a professor of health economics and finance at USC in the School of Public Administration. Professor Milner, welcome. If I may call you Glenn,
welcome.
I'll do
Thank
that.
You. Certainly.
Very good. Glenn served previously as a faculty member of the UCLA School of Public Health. He was a consultant at RAND and an expert witness to the Federal Trade Commission. But what is, I think, most relevant for us today is, Glenn, whether you like it or not, your voice now has risen to the top of those, I think, across the country, top academics that are addressing this issue of consolidation. So anyway, welcome. Good to have you with us today, Glenn.
Happy to be here, Don.
Very good. So what do you make, let's start right off the top of this allegation that consolidation increases cost but does not improve quality? Is that true or false? What do you think?
Well, I guess the right answer is it can do both, right? And it depends on the situation and the details. However, there is a growing body of literature that, when you look across a large sample of consolidated organizations, you see the price increases dominating the performance metrics rather than improvements in quality and service and things like that. That's not to say that there aren't organizations that actually do become more efficient, provide better quality or better service when they integrate. It's just that the data that we have now doesn't show that to be the predominant trend, let's say.
Well, that is important for us today and will be important for us going forward. And I'll elaborate on some of my thinking on that in a minute. But let me run an assertion by you. So I watched and read your testimony before the California State Assembly, the Health Committee. It was last October 27th, in point of fact, and I know you and I have mentioned it to one another. And as I interpreted this sort of multi page webinar and so forth, uh, you pointed out that healthcare spend per capita is unaffordable and is rising dramatically. As I interpreted your work and your presentation, much of that rise in costs is attributable to hospitals. It's not particularly increased utilization. It is mostly hospital prices. And it happens because there is less competition among hospitals, and that is a result of hospital consolidation. So there's almost a syllogism there that leads to our topic of consolidation with a lot of focus on hospitals. So is that an apt characterization of your presentation that day, or did I miss something?
No, I think that's right. I think there's an underlying model there of that focuses first on affordability and the cost of health insurance, the annual cost of health insurance, plus out of pocket spending, and by any measure, for many families, they're at the breaking point. And then if you look underneath, okay, what's driving that increase? We see, looking at California data, but in other places, it's largely in the last 10 or 15 years due to rising prices of healthcare services. Hospitals leading the way, but not the only ones. And rather than increased quantity of services or increased technology. So there was a period of time where adoption of new technology was really driving healthcare spending growth in our country. That I think is less the case now, and it's more has to do with these market structure factors that you're talking about, consolidation and other organizational market changes that make the markets less competitive.
So let me ask. So hospitals may, acquire, merge, otherwise, so that there's some consolidation. And I'm focusing only for the moment on hospitals. It allows them, perhaps, to drive higher prices because of market power, and there may be other contractual provisions. But why are they doing it? Don't we suppose that there's underlying reasons that would motivate them to do that?
Well, so one of the reasons that uh, people are, I've been talking to people across the country, is that we started studying these trends in California early on. As you know, California kind of started the managed care competitive market competition model. And if you look way back when we introduced this legislation that stimulated price competition, uh, most hospitals were independent. They were not not part of systems or large organizations, and these changes stimulated price competition. And we saw in the early days, in the early data, hospital prices stopped growing and actually started to decline in California year after year. And so that was kind of the initial market response to these pro competitive policies. After a period of time, what we started to see is hospitals started to think to themselves, I'm kind of tired of fighting with the guy across the street. If we get together, we may not have to beat each other up so much, and we could charge Blue Cross a higher price. And so we saw a wave of consolidation, of direct competitor consolidation. Now, that type of consolidation is limited by Department of Justice, FTC, antitrust laws, and regulations. And that's a fairly well accepted framework for limiting those types of mergers and acquisitions, where a small geographic area cannot become too consolidated. And so then what we see is those types of consolidation slow down. And we saw what we call cross market consolidation, where systems started to add hospitals that were not competitors of existing members, but
Right.
outside the geographic area. And so if you look over a 20-year period, you see that now, more than 2/3 of all hospitals in California and probably 80% of all patients go to a hospital that's part of a system. All right. And so if you
Right.
kind of step back and look over time, you see what the market responses to these changes and how hospitals have responded. And now we're starting to see the same, we're also seeing similar trends in the physician sector as well.
Well, so thank you for that last comment, because I think it's probably well to do a little bit of definitional work here. So when we say consolidation here, what kinds of consolidations are we talking about? We hear horizontal, we hear vertical. Who does this involve? Can you give us a little definitional background here, Glenn?
Yeah. So, a simple way to look at it is horizontal, where, I merge with a potential competitor or someone who sells the same services uh, that I do, whether they're in the same geographic market or in a different geographic market. So that would be hospitals, uh, adding other hospitals to the system or acquiring them or somehow joining together. Then you have what's called vertical integration, which is when two different sets of activities are merged together. So think about hospitals and physicians. Obviously, hospitals don't function on their own. They need doctors, are essential inputs into their into their business, into their operation. And so we see now hospitals acquiring medical groups as an example of vertical consolidation.
Right.
Uh, we see the big pharma companies, CVS and others, uh, joining up with insurance companies. So we see different examples where different, kind of market segments are now coming together into single entities or organizations that are under the same roof, same economic roof, to do strategic planning, to do contract negotiations, and things like that.
So, running APG as I do, physician groups that believe in integration, that come together in an organized fashion in order to take contracts that include a wide population of patients so that they can better coordinate the care, deliver the care, et cetera, et cetera. All of that involves really contracts, block contracts, where a group or hospital enter into a contract with a payer for an assigned population. So this is, I think, what we loosely refer to as the value movement. Yes, it involves prospective payment and other features and so forth. And yes, there's risk associated with it, but block contracts, big population. And thus, I guess the question I would ask you, does the very value movement where we have, population health, does it create a circumstance or climate where you're going to get these kinds of aggregations, vertical, hospital and group, maybe hospital, but certainly hospital and group, these kinds of aggregations that produce, I guess, an opportunity for rising prices that may rise higher faster than they should. In other words, is part of the problem here the value movement? Please say no, because I worry that it might be, right?
Yeah. Well, um, so look, I mean, the good news for California is the value movement really started here, and we do have evidence that that model can produce more efficient, more satisfying outcomes, being quality, access, uh, health outcomes, et cetera. There is evidence here in California that that model can produce, let's call it higher value for consumers, right? And
Yes.
I'm sure, and a number of your members are kind of the national leaders in doing that. However, if they were at a part of this call, they would immediately tell you that's not easy to do. Those are,
Right. Right.
basically managing population health, which is the ultimate goal of the value movement. And, it's good that we're now talking about it much more and focusing on it. And the pandemic, I think, has raised our consciousness about it. But managing population health is not easy. And so organizations that have not done it for a long time, when they move into that space, there's really kind of different models that they can do. One is they can move into that space, take on those contracts, pull together the providers needed to provide the services that they contract for. But then the question is, do they have to do the hard work in terms of really integrating their systems, their providers, right? Uh,
Right.
Managing population health. And my concern has been when you're starting with a highly consolidated market like we have, the these organizations will come together for those contracts, but there's no market pressure for them to actually engage in the hard work to increase value because the market is not forcing them to do it. And so the simple question is, look, if I'm a provider and I'm already getting above market prices, right? I'm part of a system, and our system, given our geographic footprint, we're able to sit down with Blue Cross or Blue Shield and say, look, if you want to keep us in your network, and you're going to have to keep us in your network if you want to sell insurance in this part of the state, you got to pay us 10% above market. That's it, right? And so if a provider group has that kind of power, they're not going to enter into a value type contract and give lower prices, right? They're going to maintain those high prices, and that will allow them to continue to operate the same way as before without necessarily uh, embracing and actually building a value-based delivery system. And so I'm afraid we have both types of those models here in California. Those that actually do deliver value relative to the non the non-integrated market, and then those that in name at least are value-based products, but don't necessarily make the organizational transition to do it.
So, listening to this, I think, I like to think, I have historically thought that there's examples of good consolidation and then perhaps bad consolidation. It has a whole lot to do with the motivations underlying the combination of physicians and hospitals. So I think about the IHA data that demonstrated real clearly the efficiencies associated with group practice in Medicare Advantage, where comparing the total cost of care in original Medicare, where it's outside the organized group, against the total cost of care of Medicare Advantage practice done by a group, including reduced hospital admission, huge differential. So, from memory, I think in 2015 it was like 35%. So, the elimination of waste and the increased efficiencies, et cetera, produce great savings that inures the benefit to the whole system. So as I look at physician groups, it looks to me like they're doing the right kind of thing coming together. But I listen to your testimony now before the health committee and so forth, and I can't help but note the word hospital over and over and over. There's something going on here peculiar with
Well,
hospitals that seems to be a problem. Am I right or am I wrong?
it's not. I mean, 'cause, again, the consolidation by itself um, is not automatically good or bad for consumers. So the details matter. So there can be consolidation, both horizontal and vertical, that generates efficiencies and value for consumers. The antitrust laws and the things that economists worry about is if there's too much consolidation, you take away market pressure for competition, and once that market pressure is reduced enough, then the pressure to continue to innovate, to cut costs, to make hard decisions, to achieve efficiencies, that pressure lessens and eventually disappears. And then we now are in a situation where this consolidation is actually harming consumers. So it depends on the conditions, the market conditions, uh, with respect to consolidation. For a lot of your members who are delivering value year after year, one of the reasons they do it is because there's competition in their local market. And so there's pressure on them to work late nights and weekends to figure out what committees do we need, what kinds of to look at the data we have to figure out how can we manage the care of our members better to achieve higher outcomes and lower costs, right? And those are, not necessarily easy objectives to achieve. So, as if there's market pressure for that to happen, then you're going to continue to see efforts in that direction. On the other hand, there's lots of markets where there is that level of competition even amongst your members, and so they don't nearly need to perform nearly as well to maintain their market position. The other part is it's not just hospitals that economists worry about, right? We've seen
Right.
an accelerated consolidation in the physician sector, right? Both
Right.
among primary care physicians as well as specialists. And so some of that consolidation, a lot of that consolidation may be in part driven by the growth of accountable care organizations, which contract for the whole bundle of services, not just hospital, not just physician, but everything together. And so
Right.
that kind of accelerated, uh, these organizations looking around and saying, okay, uh, you know, how do we put the pieces together without having to compete too much?
Yeah.
And
Yeah.
but we're seeing consolidation within the physician sector among specialists, so that you could have literally, a large fraction of a single specialty in a single group in a geographic area. And so, economists then worry about that. If they have a lock on this market, why should they ever agree to any changes that make them more efficient, right? Because
The
if,
answer might
if
be that
yeah.
they don't get a contract. They don't get a contract. They charge too much, and so the payer, whoever that might be, could be even a full risk group, but or a health plan, won't pay that rate, and so looks for an alternative.
Well, as long as there's an alternative, that's fine. But let's say, uh, your oncology specialists all join a single group within 50 miles of each other.
Yep. Yep.
Yeah, then all of a sudden you have no choice but to contract with that group, and then they can set the terms of the contract. And so, uh, they become a must-have supplier, be they a medical group or a hospital system. As soon as they get that must-have label, uh, that has to be part of an insurance network, then they have market power, which allows them to get above market prices generally.
So, as I look at the landscape, Glenn, you see, the medical device or industry consolidate, pharmaceutical industry consolidate. Clearly, the health plans have consolidated enormously. Are we fated to this some kind of an arms race where everybody has to get larger in order to successfully survive?
Well, I think we that is what we're seeing, right? So if
Right.
you look at all of these sectors, all of them are consolidating. So there's generally an economic explanation for that. And again, it will depend on local market conditions. I tell my students all the time, you know, trends are national, but impacts are local in healthcare, right?
Right.
And
Right.
so, particularly here in California, I mean, one of the things that's made it a great place to do research is we have very good data from the Office of Statewide Health Planning,
Hmm.
but also we have this large, diverse state. When I first started studying, there were 450 acute care hospitals. Now we're down to about 325. But still, I have other research colleagues who are jealous because we have such a large sample here with so many diverse market conditions. So it's good, makes it easier to study using our data. So, so there's a diverse set of conditions, so it's hard to generalize. All right. But in general, there's lots of research that shows Northern California hospital markets the prices are much higher than the prices in Southern California, even after you adjust for all the factors that you think would explain those differences, right? Case mix, cost of living, wage indices, input prices, those kinds of things. Um, and still prices are higher in the north, right? And then the question is why? And if you look at the systems overlay, hospital systems overlay, you see it's had a much bigger impact in the north than it has in the south, suggesting that you don't even have to be part of a hospital system to get a higher price in California if you happen to be competing with hospitals that are in systems that get higher prices. You can in a sense shadow price and still get higher prices as a result of the impact of these systems. All right. So it is a complicated story, but it depends on local market conditions. Because again, healthcare is local, right? Your members know, and hospitals know. Most hospitals, most medical groups get most of their business within a very small geographic area. Patients don't like to travel generally.
So when you say prices are higher in Northern California than they are in Southern California, you're talking about commercial, I believe. Is that correct?
Well, that's right, right. I mean, Medicare, has regulated prices, so the prices are higher in the north, largely in those places where they do surveys of wages that hospitals have to pay, and they
Sure.
adjust the amounts that they have to pay based on the input prices for those hospitals. So, uh, but the only payers that are subject to these market forces really are commercial and then to some extent Medi-Cal.
So when you look at this commercial Medicare differential in Northern versus Southern California, we've argued for years about the labor cost inputs and so forth in terms of adjusting these things. But the benchmark by which MA is calculated, the fee-for-service spend in Northern California, is strikingly lower than it is in California, creating a dynamic that some have argued produces a sort of cost shift. In other words, to keep hospitals open in Northern California, you got to charge more for commercial because you're getting paid a whole lot less for Medicare. And in Southern California, the obverse is true. You can get away with charging less for commercial because there's a higher benchmark and county book rate and so forth, and you get paid more for Medicare. What do you
Yeah.
make of that dynamic?
Yeah, well, so the old saying, correlation is not causation. So those sets of numbers may be true, but and this whole issue of cost shifting has been debated, for some time in the health economics literature. Uh, I think most economists, have reached the point where they don't subscribe to the cost shifting argument. And if a simple thought experiment is, you know, let's take hospital prices to Blue Cross in Northern California, right?
Okay.
And
Yep.
let's assume that tomorrow Medicare doubles the amount that it pays those hospitals for Medicare patients. Would those hospitals then call Blue Cross up and say, "Oh, we just got a big increase in Medicare, so we're going to give you guys a discount"? The answer is no. That from an economic perspective, without getting too academic here, the
Yeah.
objective function of these organizations is largely to maximize revenue and then if they're nonprofits, to use that revenue to do, do other things with that money. All right. But I don't know any organization that has as part of its objective function having the lowest prices in the state or lowest prices in town. All right. You only see that in competitive markets where then you have to have the lowest price in order to maintain your market share. So this argument, that it's necessary, it just doesn't follow the economic, economic literature. There's also been studies that show, that basically when these organizations get more money, they just simply spend it on other things. All right, and so they allow their costs to go up. All right. Another way to think about it is there are quite a few hospitals in California where, I don't know, 70, 80% of their volume is Medicare plus Medicaid.
Yeah.
And they're still in business.
Yep.
Right. So they're able to survive under those pricing regimes also.
Yeah, no, it sounds very, very, very complex. So, apart from the cost shifting, which of course is getting ever more fascinating now with the recent Trump regulations on transparency that have obliged hospitals to post their prices. So, this isn't where I intended to go with this, but it is indeed shocking to see. I won't use the words for the sake of discussion at the moment, cost shifting, but the differential between the amounts paid for Medicaid versus the amount paid for Medicare versus the amounts paid for commercial versus the amounts paid for out of network commercial, if I can call it that. I mean, the spread is 9 football fields wide. It is an amazing dynamic. Any further thoughts? Is that a bad thing? Is that a good thing? Should that be addressed?
Right. So, well, one of the factors that explains those differentials is, what economists call monopsony power, right? Which is
Right.
the consolidation of buyers, right, within a single entity, right? So there's monopoly power, which is the seller side. Then there's
Right.
monopsony, which is the buyer side. So, Medicare is the largest single buyer
Yeah.
of hospital service, even though it's only 12% of the population. It's 35 to 40% of all the admissions in
Right.
California. So a hospital looks at Medicare and says, can I, do I want to be, have my organization run without Medicare, and I'm not going to agree to their prices, or, and am I going to give away 30 or 40 or 50% of my revenue simply because, I'm not getting the prices that I want? And so the same with Medi-Cal. In the hospitals that, it tends to be concentrated in a subset of hospitals. It's also the largest purchaser or a large purchaser. So this issue of monopsony power comes into play here. In general, economists look at that as benefiting consumers, right? Because now you have, instead of individual consumers trying to negotiate a deal with a hospital, they come
Yeah.
together in large groups. All right.
Right.
Now, there is a concern, right, that if monopsony power gets too great, that quality and access could suffer. Prices could get so low, right,
Right.
that the other dimensions of the product will suffer. All right. And
Right.
provider groups argue that all the time. All right. And so the problem there is, that the Medicare is acting as an agent for Medicare enrollees. Right.
Right.
So so the enrollee doesn't get a direct input into these decisions. Medicare does extensively monitor access. They do all kinds of surveys and things like that to monitor access, availability, waiting time, all those things for its members. So they are paying attention to those dimensions. And so, but obviously, this is a very important factor because if we look over the horizon at an all-payer system or a
Right.
Medicare for all or anything like that, that is going to substantially increase monopsony power,
No
right?
question. Yeah.
And then these other dimensions, come into play, much more strongly.
So, notwithstanding the arguments about cost shifting and the realities underlying it, if Medicare is paying, as my hospital friends tell me, whatever it is, 80 or 90 or something percent of their cost, something slightly below cost, Medicare we're talking about, to the extent that we shift everybody into Medicare, look out. I mean, all of a sudden the hospital's underwater. I mean, they need the commercial population with the higher payment to keep the doors open. I have a hard time not finding that to be a persuasive view of how their finances work, notwithstanding the cost shifting arguments. So what do we do? As we kind of wrap this up, Glenn, if we've got consolidation, it does seem to be driving higher prices. Healthcare is ridiculously costly, unaffordable for many, and seems to be out of control, basically. So, what are your thoughts on measures that could be taken to remedy this problem?
Right. So, as an economist, I still believe that the market, when it works well, is the best friend of the consumer, because market pressure creates competitive pressure, and you have all these entities, working day and night to get my business uh, at the best price, at the quality that I want, at the service level that I want, all the things that consumers value. The market delivers those if you have the right conditions, right? And as
Right.
when we started this conversation, we talked about there was a period of time where we had real price competition in California's healthcare system. And so you look back at that time, prices were going down, premiums were going down. If you can imagine that,
Yeah, no, I recall. I remember.
premiums were going down year after
Yeah.
year.
Yeah.
All right. And then, what happened was the so called managed care backlash. Right.
Hmm.
Um, and, what that did is that started, a couple, it limited the ability of your members actually to control utilization of emergency departments,
Right.
hospital emergency departments. And at the same time, we started to see, in response to price competition, increased consolidation in the hospital sector and the growth of systems. All right. So, I think we need policies that will restore competitive conditions to the market. Failing that, the only remaining solution to continued rising prices will be a government takeover of some kind. And so I'm hopeful that policymakers, will intervene to restore competition to the markets so that the consumer's voice still plays a role in service quality, accessibility, availability, all the things that we value, and that we don't turn all of that over to a single entity like a Medicare, because then they end up making all the decisions for consumers. They substitute their judgment for individuals, right? And so we lose
Right.
that responsiveness. So, having followed policy now for the last several years, I think the most important thing is transparency. We need to get the data out there so that consumers understand what's going on, and they put pressure on policymakers to enact reforms that will make the markets more competitive.
But will they, when all they have to pay is their copayment, their coinsurance, their share of premium, high numbers to be sure, But will they really notice the difference between case rates of hospital A and hospital B? Or is it the consumer, or is it really the purchasers of healthcare, as in the employers, CMS, Medi-Cal, and the like?
It's
But
not them.
who
It's
needs the transparency?
the families, the people who sit around the kitchen table don't really understand how much rising healthcare costs is hurting their family budgets. They don't really understand. They think because my employer is paying for a chunk of my premium, they're just giving that to me for free. Well,
Yeah,
the reality is they're not. They're taking that out of your compensation. All right. And so, there are literally millions of Californians who make, $15 an hour who are going to be stuck there because any potential increase in take home pay is first going to be allocated to paying the premium for their insurance next year. Right. Most people
right.
don't understand that. So there has to be a growing chorus of outrage that says this is no longer acceptable. You're going to have to enact policies that make life more difficult for healthcare providers. They've had it too easy for
Yeah,
the
yeah.
last 25 years. You look at any one of their budgets, it doesn't matter, recession, non recession, whatever, their budgets go up year after year after year, right? They are immune to the economic forces that everybody else is subject to. And that's just not sustainable on a long-term basis. And it's families that either through higher taxes, higher contributions to Medicare, and bigger chunks out of your take-home pay for premium, or bigger out of pocket. And so that has to get out there so that there's pressure on legislatures to fight back when providers come in and say, you're going to bankrupt us if you do this change. Right? And they say, well,
Right.
I'm sorry, you're bankrupting, millions of families in California. You're going to have to work harder.
So I certainly get the dynamic that leads to wage stagnation. I've for long wondered how employees and consumers tolerate the dynamic you've just mentioned, but they don't seem to connect dots very well, in my personal opinion. Though I know others do, policy wonks do, employers do. So I get it and agree that transparency should be a big help. What do you make of antitrust enforcement? Historically, that
Well,
hasn't done much. Is that a tool that the government should be using more or less?
so I think we talked about before the types of consolidation. One problem is the federal apparatus for antitrust has typically looked at local market mergers
Right,
and really has kind of ignored the out of market consolidation, which is now driving consolidation and price increases. So I think more of that is going to fall to the states. There are a number of states that already do reviews for those kinds of consolidations. There was proposed legislation here in California. I think that's an appropriate mechanism at the state level, that there be a review of consolidation. The details, matter. You want to have a program in place that doesn't disrupt the market, but rather maintains competition and restores competition without necessarily slowing things down. One problem with these reviews is they can go on for a long time, um, and be disruptive to the market. So we have to design them so that they're efficient as well. But I thought about maybe a policy change that we're seeing at the federal level. At least one change that I think will be very helpful is limiting the ability of hospitals to charge extremely high prices for out of network emergency care.
right.
Right, that has been a tremendous threat to Blue Cross, Blue Shield, all the plans, uh, to not let them out of their network and therefore having to pay them higher prices. I would like to see that, you know, further enforced here in California more quickly. What if you did that change? You could then actually have legislation that says, every provider should have a contract with every health plan. And then you could just negotiate the price. Because I am also worried about, as these systems form, you may have 10 hospitals in a city, but once the systems start to carve up the market, it may turn out that, my access to 6 of those 10 hospitals is cut off because
Yeah.
they're in a different system.
Yep.
It just happened to me when I went to get my lab test done. you know, and well, no, we're no longer part of that system. We can't do this lab test. I said, well, I was just here last month and you did it, but now you're telling me you're not doing it because my doctor's not part of your system. So I'm worried about access, that the market be so segmented into these systems because they're all trying to protect their market share, protect their prices, that consumer access and continuity is going to suffer as a result also.
So you're touching on, to a large extent here, the surprise billing issue, right? Which California has addressed significantly, I think, through a regulation a number of years ago, and
That was
where
on
it
the
exists.
physician side, not on the
Yes,
hospital side.
it was on the physician side. That is correct. And frankly, I don't know exactly where it stands in Congress right now. It's been debated and fought out, and I think we have a
Well,
bill.
it's been
Go ahead.
passed. It's been
Yeah,
passed.
yeah, yeah,
So
yeah.
January of next year, um, the there's a cap on out of network emergency bills by hospitals. And what it says is, if there's a dispute, it goes to arbitration. And the good news is, the law says the arbitrator is no longer allowed to consider as a reasonable price the full bill charge that the hospital lists on its charge master.
Right.
Because as we all know, those are incredibly inflated and not meaningful prices. So the good
Yeah.
news is the arbitrator cannot take that into account. And so that provides some protection to consumers also, that they can go to any emergency room, get the care they need, and it's not going to be this pecuniary price that either they or their plan is going to have to pay.
It,
That will help a lot.
we've fought that out for years. So you touched. I'm going to wrap up, Glenn. You mentioned capping costs in the context of out of network there and the surprise billing. What is your view of rate caps more generally? They're being discussed in California, I think, now in connection with the Office of Affordability and elsewhere. And of course, they exist elsewhere also. They are a de facto cut in provider pay if they're not indexed to inflation, which oftentimes they're not. So they don't warm the cockles of the hearts of physicians, I don't think, in the main. What is your view of rate caps and the like?
Well, again, as an economist, there's this saying in the field that regulations are always a second best to the market, right? If you can have a functioning competitive market that has all the right incentives, then consumers get the best price for for the service and quality levels that they want, and that protects consumers across all those dimensions. Once you have a third party setting the prices, they substitute their judgment for all these other things, and then also the concern is it becomes budget and politically driven number,
Yes.
which further divorces consumers and what they want from the process. One need only look at the UK, right?
Hmm.
And see how they struggle. They'll go for 10 years without an increase, and then things will blow up, and then there'll be a big increase. So, most economists are not big fans of government regulated prices because they tend to be, not particularly responsive. All right. But on the
Yeah.
other hand, given the affordability problem, uh, if we don't restore competition to the markets,
Right.
policymakers, the pressure will grow,
Right.
and policymakers will, feel that they have no alternative but, to go to some kind of regulated model, because that they could, it's simple. it's simple. Whereas markets are complicated and messy.
So one of the arguments we make in this conversation is, look, if you adopt the best delivery model and payment model, and by reason of its intrinsic structure and aligned incentives, it makes a profit on eliminating waste. Might that not be the solution in lieu of
Uh,
regulation and price caps and single payers and so on? What do you make of that?
oh, I like that. I mean, as long, but but you still have to look. Your successful members are effective only in certain parts of the state. I'm sure. I'm sure there
Right,
are other parts where that model doesn't work because of local market conditions, right? There's the specialty market that they have to buy services from is too consolidated, and so those docs won't sign a contract unless it's 500% of Medicare, right? So there are other so is we need to restore competitive conditions in order to create the incentives that align the incentives for that model to work.
so, Glenn, as we look at the prospect or possibility of single payer and high levels of regulation and a marketplace that's not working really well, I looked at my members. I'd like you to react to my observation here. Yes, they're principally in metropolitan areas where there's a high density of patients and high density of physicians, so that organized systems can best be put in place. Their bottom line is derived by reducing waste writ large, right? So the unnecessary admissions and avoidable treatments, et cetera, et cetera. And so that's where they derive their profit. And so I like to think that that model is the model for the nation, as opposed to reducing physician pay, high levels of regulation. What do you react to my thinking?
Uh, I would like to agree with you also. I mean, I think certainly the California model would generate tremendous savings across the country. As our doctors in California over the last 20 years, and many of your members have learned how to manage care cost effectively. And that is not widely done throughout the rest of the country. So
Right.
that model would be a fantastic export. Um, Coming back to California, however, though, is I'm worried that your groups, even if they have been successful so far, if they face an increasingly consolidated hospital market
Sure.
and they have to negotiate year after year with now fewer and fewer hospital options that they can take their patients to, they're going to face rising prices that then have to be passed on to consumers. Uh, so even though they're managing care, at the end of the day, they still need these other inputs. And if those input markets are consolidated, those prices are going to go up, and the rate of increase is going to continue to go up. So
No, I agree.
that's the worry.
Well, I concur in the worry. I mean, a significant percentage of my members are full risk. In California, they have restricted Knox-Keene licenses, and they're paying hospital claims. So if those hospital prices are rising astronomically, which they are in some instances, they pay them, and that is a problem. And we're a payer, as at the same time we're a provider. Um, so the hope of reducing avoidable admissions and unnecessary utilization with the hospital, while a good one, the worry is that it gets outstripped by, really steep price increases. So we're at the table, both sides of it, provider, payer, and clearly a huge stake in this outcome. So anyway, wish us luck, Glenn.
Yes, absolutely.
Well, thank
Well,
you
wish
very
us all
much.
luck.
Well, I wish us all luck. Really appreciate talking with you, and we will do it again soon, I hope.
Good. Yep. Anytime. Good talking with you,
Okay.
Don.
Thank you very much, man.
Bye-bye.
Okay, take care.
Thanks for listening to APG on American Healthcare with your host, APG President and CEO Don Crane. For more information about APG and transcripts of this show, visit the APG website at apg.org.